Welcome, everybody. I'm Laurie Cadden, and this is the 10th edition of the Lackawanna County Medical Society's Public Health Education Series. We're having a wonderful, spirited conversation here with 4 doctors, and we're going to be speaking about renal cancer awareness. And we have a few questions I'm going to ask. Hopefully, maybe some audience members will ask some questions. We have a few cancer survivors in the audience, and we're going to get started with the introduction. So thank you. This is funded in part by CHS. So I'd like to introduce our panel. We have Dr. John Farrell. We have Dr. Don Priate Jr. We have Dr. Jeffrey Gruen, and we have Dr. Madhavid Bakati. They are all going to speak a little bit today, a lot of it, I guess, Dr. Priate, on cancer, renal cancer, and the significance in our area, and how it can be treated, and a lot of different questions. To the point, I think, John, I have 20 questions to ask you guys. What do you think of that? 20.
That's good.
Lisa gave me a ton. Usually it's 6, 7. She gave me 20 this time. So anyway, I'm going to throw them out. You guys, please, free form, whatever who wants to jump in and answer. You can all answer together if you can do it in unison. I don't care. Whatever you want to do just to get the information across. So let's start with a very basic question. What are the kidneys and what exactly do they do?
I guess I'm probably the most appropriate to start off with that from a urology perspective. Everybody has 2, or should at least have 2. They are pear-shaped organs measuring about 4.5 inches in length, and they're located in the retroperitoneal space in the body. Well hidden in the back, sheltered by some muscles and well as the bones, and the 2 ribs around the front, the 11th and 12th, which are free-floating, sort of kind of give a little bit of extra protection for the kidneys as well. Kidneys are extremely important. You can't live without them. These are basically the filter or cleansing part of the body. They can receive about 180 liters of filtrate per day to produce on average about 2 liters of urine. The kidneys are very important for fluid balance, making sure that the body gets rid of excess fluid that it doesn't need. It's also important for acid-base balance to keep pH levels proper in the body. It also produces chemicals that are very important for homeostasis of the body. Renin is a chemical produced by the kidney, which is important for blood pressure maintenance. Calcitriol is also important for calcium homeostasis and the production of erythropoietin, which is important for production of hemoglobin from the bone marrow. So, you need your kidneys to live and survive. You can live with one. You can live with part of one. If you don't have any kidneys, you need to have dialysis. So, very important structures.
Mm-hmm. And let's point out, too, and if, doctors, if you would, in the beginning when you speak, if you could say exactly the type of medicine that you practice. We do have a urologist, as Dr. Priate just mentioned, which he is. We have a medical oncologist. We have a radiation oncologist, and Dr. Farrell is a radiologist. So if you would introduce yourselves as that so that we understand exactly which one is answering the questions and why obviously the kidney answer would come from Dr. Priate as a urologist. So the next question is, since this is really what we're talking about today, is renal cancer awareness. Could you explain to us what is kidney cancer and are there different types?
My name is Jeff Gruen. I'm a medical oncologist. I'll take this one and I'll combine it with question number 4, what causes renal cancer. So renal cancer is when one part of the kidney goes crazy. It just starts growing without boundaries, sort of like a lump of tapioca pudding, and it just starts expanding, and eventually jumps throughout the body. There are different types, there are different parts of the kidney, different types of it can go bad, so there are different kinds of kidney cancer. But the predominant one, a clear cell kind of kidney cancer, is very common, put it that way. What causes these things to go bad is a very nice story that we've learned about what is kidney cancer and what causes it. And it goes back to about 1907 when two docs named von Hippel and Lindau started describing families with kidney cancer. It was very rare to have a family with kidney cancer. So they described it and it became the von Hippel-Lindau syndrome. It turned out that years later, so about 80 years later, in the 1980s, they figured out the genes that cause kidney cancer in these families. And they are applicable not only to the families, but to, in general, anybody's kidney cancer. So we now call it the von Hippel-Lindau gene. And we know that when this gene goes bad, cells start growing. And it causes kidney cancer primarily. Can be one side or rarely it can be both sides. But so we now know the genetic causes of kidney cancer, and it's nicely lined out in the literature. It allows us also to design drugs that stop these gene mutations, specifically what we call targeted therapy that stops it. So the whole story started in 1907, but it really became important in 1980s, 1990s, and 2000s when we learned what the genes were, what causes kidney cancer, and how to stop them.
Doctor, in that case, if someone is to get a blood test or to understand your genetic, what would be the best? Would you recommend that people who have a parent or someone with kidney cancer, that they be tested to understand if they have the gene as well?
We usually test you if you have more than one family member. One family member is a coincidence. If you start having more than one family member with kidney cancer, then we start getting nervous and we do the genetic testing.
Okay. So in that case, then, I guess this is a loaded question, but can anybody get kidney cancer? Is it more specific to one gender, age? Who gets it? Why?
I think I'll take that one too. Kidney cancer is not one of the most common cancers that we do see. There's about 65,000 new cases of kidney cancer diagnosed every year and approximately 50,000 deaths. There is a gender predominance. I would say about 2/3 of them tend to be males age 65 or older. However, kidney cancer, especially clear cell carcinoma, can be diagnosed even in children. Less likely in people less than 65, and even 1/3 less in females. Kidney cancer, most of it is, as Jeff had pointed out, is renal cell carcinoma. That's 90 to 95% of them is the most common. Most of them arise from the proximal convoluted tube, which is one of the structures of the kidney. Secondary types of cancers would include papillary carcinoma or chromophobic carcinoma, and then there's a myriad of other types of kidney cancers that are much more rare. We do see that most kidney tumors, if you want to use a generic thing, are 80% renal cell cancer, which is what we're talking about today, and 20% tend to be a urothelial cancer, which is transitional cell, a variant of like bladder cancer, which comes from the lining of the kidney. So that would be a different topic from a different day, but renal cell cancer is the one we're focusing on now.
This is Dr. Bakari. I'm a radiation oncologist. Kidney cancers also can be found in children. It's a peculiar type of tumor. We call it Wilms tumor in children. It arises from the embryonic crest, and that is seen predominantly in children, and they're highly treatable and curable today with known medicines. So children also can be affected as a subgroup of patients. Otherwise, it usually affects the elderly.
Could you explain, too, just for the sake, are renal cancer and kidney cancer, the term, is that used interchangeably, or is there a distinct difference?
Kidney cancer is more the generic term for various different types of cancers. Renal cell would be the particular kind that arises from the parenchyma or the meat or the heart of the kidney. Again, 80% of those are renal cell carcinoma, and then 20% are the urothelial version, different type.
Okay.
And then renal cell cancer is, broken down into those other various definitions: clear cell carcinoma, papillary, chromophobic. It's basically what it looks like under the pathology.
So if someone has kidney cancer, I'm going to break off a little here and not breaking any HIPAA regulations because she has to like me when I leave. It's my mother. So in fairness, my mother would have no idea and had no idea that she had kidney cancer, and on a long time coming of all these different tests and everything that was happening. Symptoms, and that was the last thing we thought we would hear in December when we sat in her doctor's office, and that's what they told us. So how does somebody know that is that a type of cancer, that there's any real specific symptoms, or what is the best way to know if that's what's going on with you, if a patient actually does have kidney cancer?
I'll take that question, Dr. Bakari, again. Most important thing, the three important symptoms is gross painless hematuria. Blood in the urine is always abnormal, and when they have massive bleeding, they bring to our attention. And there is usually a pain sometimes, and also a palpable mass. And that sometimes the patient may or may not be aware of this. And the more recent imaging studies, ultrasound, CAT scans, etc., sometimes they're done for some other reason, and we incidentally figure out a kidney tumor, and that is asymptomatic, meaning the patient may not have had symptoms arising from that, and that probably accidentally leads to an early diagnosis and usually has a better outcome.
And doctor, you're a radiation oncologist, so if we have two kidneys, if one, in my mother's case, had cancer and the other one did not, and it was contained to just that kidney, who then requires radiation? Is it because it goes elsewhere in the body, or do you actually treat the actual kidney?
Well, there are various trials that have not conclusively proven that radiation is useful in an adjuvant setting after surgery for primary resection of nephrectomy. So most of the time, we usually use radiation for palliative symptoms, either when the cancer has spread to the bone or into the spine and maybe causing spinal cord compression, or travel to the brain where it causes other symptoms of stroke-like effects, and also sometimes rarely even in the lung. If there is a multiple lung metastases, one could use local radiation treatment to freeze the tumor at that time.
And I'm going a little off script, Lisa, if you can tell, but some cancers start somewhere else and it's detected elsewhere. Kidney cancer, and anyone can jump in on this, that actually is where the origin, that's the beginning of it, and it can go elsewhere. I know, Dr. Priya, you had said it likes the lung, I think you said the liver, the brain, but it actually, that is one cancer that actually starts where it is and then can go elsewhere. But instead of another cancer, sometimes it says, well, it really didn't start there, it was somewhere else and ended up there. Is that pretty true?
Yes, to compound what my colleagues had stated here, that the classic triad of gross hematuria, flank pain, and palpable mass, believe it or not, only presents in about 30% or less of patients. So 70% of patients don't even actually have the triad of all of those things all at one time. Sometimes other nonspecific symptoms like weight loss, fever, high blood pressure might be other, or just general malaise, I don't feel good, might be symptoms that might have presented. Most kidney cancers are 60% of them incidentalomas that my esteemed colleague here, Dr. Farrell, will pick up accidentally when he's doing an x-ray for something else, whether it be back pain or, pain suspicious for a kidney stone or, weight loss, and, sometimes an x-ray is done or an ultrasound maybe is even performed, and then, they see something suspicious, and then later they get a more definitive x-ray to look for what we're doing. Other tumors can metastasize to the kidneys, breast cancer, lung cancers, adrenal tumors can metastasize to the kidneys. And in those cases, you'd be looking at secondary tumors. But I would say most masses that we detect and find are usually primary, arising from the kidney. And then, the whole key is trying to determine at what stage are we finding them. Are we finding them confined to the kidney, or are we finding them, involving other organs or other parts of the body?
Well, I know that from my mom's doctor saying that when she had all this blood work done to see what was going on with her, they kept saying her SED rate was high, which I have no idea what that means. Now I just know the term, so I throw it around like I really know it. I don't, but that is indicative of cancer. So if that's the case with blood work, suspicion, then John, I guess you can jump in on this, Dr. Farrell, answer how is it diagnosed then? Through forms of testing that you would do, correct?
Yes, I'm John Farrell. I'm a diagnostic radiologist, and it's often diagnosed with imaging. The point that is important is that there is no good screening test for renal cell cancer. We have screening tests for other cancers, mammograms for breast cancer, PSA tests for prostate cancer, colonoscopy for colon cancer. But we, in general, don't screen the population for renal cell cancer. There are some individuals who have genetic disorders, who have a predisposition to renal cell cancer, as Dr. Gwynn was mentioning, who may get screened with ultrasound or CAT scan. But as Dr. Priate said, most of these masses that we pick up are what we call incidentalomas, which is a quasi-medical term for something we pick up by coincidence. Okay, so many patients will have who get a lumbar spine, or every patient who gets a lumbar spine MRI, we can see at least part of the kidneys because the kidneys are so close to the lumbar spine, to the back, that we basically get a free look at the kidneys. And so it's not uncommon to pick up a kidney mass for a patient who has back pain. Patients can get abdominal CAT scans and ultrasounds for many reasons. There's so many different causes of abdominal pain that primary care doctors will often order abdominal ultrasounds, renal ultrasounds, or abdominal CAT scans to investigate a cause for abdominal pain, and that is often the source of, or the way in which a renal mass is found. And it's not usually related to the patient's symptoms. As Dr. Priate said, it's often asymptomatic, meaning the patient doesn't know they have this. It's a diagnosis that we kind of come to because we are not necessarily looking for a kidney tumor. We are looking for something else, and we find a kidney tumor.
Okay, so what happens next? Once a kidney cancer is diagnosed, what would be the next plan of action?
Well, basically the first part is, again, as your original question had asked, Lori, is like, are there blood tests for this besides the accidental x-ray that might come across it? Kidney cancer is notorious for causing paraneoplastic syndromes, and Dr. Grin might be able to touch upon that as well, that patients might have anemia. Obviously, as I had mentioned before, the kidneys produce erythropoietin, which helps in blood production. So if your kidney is not functioning properly because it's being taken over by a tumor, you may not produce the proper chemical that might stimulate the bone marrow to produce blood, so you might be found to be anemic. Other types of paraneoplastic syndromes would be increased calcium production. So if we see that there's elevated calcium levels in a patient, that could be the suspicion of a tumor. Now, it doesn't necessarily mean kidney cancer. Other tumors can cause these types of things as well. But those would be the main ones that you would look at. ESR, the sedimentation rate that you had mentioned, is a non-specific test for inflammation or something unusual going on in the body. Dr. Grin probably could mention how they use that in hematology, oncology, more so as a non-specific test. But anytime the body detects something wrong, the ESR rate might be elevated, such as in cancer or infection, or even arthritis can cause an elevation in that as well. Simple urinalysis to look for microscopic hematuria might prompt evaluation with an ultrasound or an X-ray, such as a CT urogram, to find out if there's kidney stone or possibly a tumor. So that's usually how we start off with. The gold standard imaging study for kidney cancer is a CT urogram. So basically, you're administering some contrast, if the patient can tolerate it with appropriate renal function, to see if a solid mass that is detected lights up with contrast. Any type of solid mass that has enhancement qualities, by definition, would be worrisome for a renal tumor. 99% of solid masses of the kidneys are bad. They're usually malignant. So there are some benign kidney tumors, such as oncocytoma or adenomas, which are not worrisome as much, but they're rare and few and far between. So usually when we find solid masses, is when we get a little worrisome. There was a classification named after Bosniak, Bosniak, who basically looked at renal masses that were discovered, whether they're cystic, partially solid, or completely solid. And this was a way to determine if a mass is worrisome or suspicious. His classification divided things into a Bosniak class 1, which would be a simple renal cyst, basically a ball of water. Benign and nothing to worry about, although I would, on occasion, maybe check that once or twice a year or every other year just to make sure things are fine. A Bosniak class 2 classification would be a simple cyst with a single septation through it, but nothing worrisome for a tumor. Other types of cysts that are in the Bosniak 2 classification would be like a hemorrhagic cyst or a proteinaceous cyst that, again, looks simple but has abnormal fluid in it. We would probably keep an eye on those. Bosniak 3 classification would be a mass that has a cyst but a solid mass within it. Those are suspicious and treated for cystic renal cell carcinoma. And then there's the Bosniak 4 classification, which is a solid renal mass, which is obvious kidney cancer. So those are kind of a radiologist guidelines for looking at solid masses or masses of the kidney.
Okay, so if they have that diagnosis, it's proven, okay, we have kidney cancer. The next step then would be to determine what type, whether it needed to be, the kidney always need to be removed if in fact you are diagnosed with kidney cancer?
Well, I'll pick that up. As a medical oncologist, patients often come to us with masses and say, do I need to undergo surgery? And the answer is almost invariably yes. If you have a solid mass, there and you're healthy enough, it needs to come out. We don't biopsy them so much because in the past when patients had been biopsied, when you stick a needle into one of these masses, you could spread the tumor along the track of the needle. So we rarely biopsy. Once in a while we do, but we rarely biopsy them. If we're certain it's a solid mass, most of the time the patient goes directly to surgery and gets either part of his kidney or the whole kidney taken out. So we do see these folks in reference. People say, I want to spare myself going through the surgery, and I say, sorry, you really don't want to spare yourself going through the surgery, and that's how we both confirm the diagnosis and treat it initially.
And we get this question a lot, Lori, is, well, how come we don't biopsy to see that it is cancer? And, Jeff's point is well taken that, there have been some anecdotal cases of sticking a needle in it that you could spread the tumor cells along the tract, particularly for renal cell carcinoma, as opposed to other types of tumors. There's also the false positive or the false negative. If you stick the needle in it, what if you didn't get cancer?
Yeah.
Does that mean it's not cancer? Not necessarily. Or what if it came back positive and it really was a benign tumor version? So, there's also the complications of doing the biopsy. Sticking a needle into a vascular organ, with surrounding tissues doesn't necessarily mean you're not going to cause bleeding, infection, damage to adjacent structures. So, there's the risks of doing the biopsies. And I think it comes back to the main point that, if it looks suspicious and is solid and 99% of them are malignant, we just treat them like they are. So you can kind of skip that step. The next thing, to Jeff's point, is, kidney cancer basically is a surgical disease. If you find it, you hope you find it early. And even in cases where it can be, which we probably will talk about shortly, the staging of it, even in advanced cases, sometimes surgery can be quite helpful. It's helpful sometimes to know exactly what type of tumor you're dealing with. There have been case reports that also show that debulking a tumor can sometimes help with keeping it at bay or maybe increasing longevity. We do know that stage 1 and 2 cancers, when diagnosed early, survival, 5-year disease-free survival rates are almost 65 to 90%. So that's a pretty good statistic. A stage 3 tumor, which might be involving into the blood vessels or the lymph nodes in the vicinity of the kidney, it starts to drop down to about 55% in terms of 5-year survival. Stage 4 kidney cancer, when it gets beyond 5-year survival, 5 to 10%. Okay. So, the better you can get these things earlier, the better chance of survival for the patients.
As far as cancer, I know we're specifically talking about kidney cancer, but it seems to me, because you have 2 kidneys, that if you're going to be diagnosed with that type of, as Dr. Grin said earlier, and doctor, excuse me if I'm incorrectly quoting you, but you said that it was not as likely that both kidneys would be affected. Did I hear that correctly? Or
it's very rare.
Okay. So in that case, if the beauty of a kidney is that you have the other one that can operate beautifully, right, in most cases, to go on with a normal life, unlike another organ that you absolutely need that just can't be removed. And in that vein, did you do, if someone has kidney cancer, Are there oftentimes that if it's advanced, do then they have to go on dialysis or to aid in what the kidney actually does, or are they two separate things?
Well, I can take that question. Basically, you need at least one healthy kidney to survive. Now, obviously, God gave us two kidneys,
Right.
and obviously one kidney is removed, the other kidney has to take over the function of the kidney we lost. So that stresses that organ. Any condition like hypertension, diabetes, any of those conditions can perpetuate and cause more problems. Now, if the kidney gets infected or any other those kind of things, then you impair renal function, then you have a trouble, because if you are not able to come up with the complete removal of all the waste material from the body, the kidney can be stressed. The dialysis may be one other choice.
Okay.
That is why it's a surgical treatment of renal cancers and nephron sparing, or kidney, part of the kidney can be spared if at all possible. That is probably advocated, because that reads that at least give enough renal function for the kidney to function better.
Wow. Okay, so if someone is diagnosed with kidney cancer, should everybody get a second opinion, in your opinion? Anyone can answer that.
I'll pick that up, because again, patients often come to us saying, I don't want surgery. Patients are scared of surgery. Or they say, should I get a second opinion regarding surgery? The treatment for kidney cancer is very standardized nowadays. For routine kidney cancer, I don't think one center with a big name offers anything than any other center. It's very standardized treatment. There are some specific cases where you might get a second opinion, but for the basic treatment of routine kidney cancer, the treatment is very standardized, and it's the same no matter where you go.
Yeah, I will second that. I think we have excellent local facilities, and I don't think it is mandatory that everybody get a second opinion. And I think if peace of mind, if anybody wants to get a second opinion, you can talk to your oncologist or a surgeon, and he will facilitate a second opinion fairly quickly.
So then do we want to talk, I know we just touched a little bit, but could we be very specific about then the actual treatment of kidney cancer?
As my two colleagues had stated here, that surgery is the mainstay for kidney cancer, and the gold standard today has become nephron-sparing surgery. It would be nice if we had small cancers with extremely healthy patients that didn't have a lot of comorbidities, but a lot of our patients that we see today do have diabetes, high blood pressure, hypercholesterolemia. They may in fact even have compromised kidney function to begin with. Most kidney cancers, for the most part, are found in the older population. So as patient age, there's definitely increased risk for performing surgery on these patients at that time. So when you take all these factors into account, sometimes that can affect patient choices. We haven't even mentioned it here, but in some elderly patients that might be risky for surgery, we know they might have a kidney cancer, but if it's a small enough tumor and they're not symptomatic and maybe they have significant other comorbidities, watchful waiting is an option that's also offered out there. We typically like that for smaller lesions, and keep an eye on them every 6 months, with periodic imaging studies to look to see if there's changes or changes in their symptomatology or the status of the tumor. Obviously, faster growing lesions might prompt us to want to do something when we previously thought we would watch it. But historically, right now, the gold standard is for small renal lesions, 4 centimeters or less, in order to maintain renal function in the possibility that patients might have other comorbidities or deterioration of their health over time. It's best to have 1 3/4 kidney if at all possible. Larger lesions tend to be more infiltrative, may involve full thickness parenchyma into the kidney or the collecting system, or even have a higher risk for spread to local lymph nodes. So the TNM classification for tumors right now basically is if your kidney tumor is 7 centimeters or less and confined to the kidney with no obvious involvement of tissue beyond the kidney or elsewhere, it's considered a stage 1. If you're over 7 centimeters, just by the size, you're considered stage 2. A stage 3 kidney cancer would be one that might involve the fatty tissue just around the kidney, or possibly kidney cancer can form a tongue tumor thrombus that can grow into the vein and can actually weave its way up through the blood vessel of the body, the vena cava, all the way up into the heart. Those are stage 3 kidney cancers, and then stage 4 cancers would be ones that are distant metastasis. So anytime we diagnose a renal mass, regardless of its size, the next mainstay thing would be to do a metastatic workup. You know, typically I will order a CT of the head, especially if there's any neurologic deficits or complaints, bone scan because it likes to go to the bones on occasion, and sometimes a CT of the chest looking for lung nodules. And then again, most of these patients have had a CT abdomen and pelvis looking for lymph nodes and making sure that the tumor that's on the side of the kidney seems to be confined and that the other kidney looks good too as well. Sometimes patients could have a solitary kidney or might have had prior surgeries, and you know that may impact on the choice of therapy. Equivocal cases of CAT scans with enhanced imaging, sometimes we'll do an MRI. You know, maybe we get a better picture on an MRI if a CAT scan doesn't give us all the information that we need.
So as far as side effects for treatment of this, I mean, I know we said if it's stage 1, it's removed, it's usually as it's a surgical cure, but other treatments that happen with kidney cancer, what are the long-term or the side effects of having the kidney cancer dealt with in other ways?
Well, I deal mostly, for medical oncology, I deal with metastatic, so when the tumor is spread all over the place, and we treat them with chemicals. We treat them with a variety of pills and intravenous things that are specific for kidney cancer. The side effects are not as bad as, these are chemotherapy agents, but they're not as bad as the old days. You don't get hair loss, you rarely get nausea and vomiting. You can get some mild problems like GI upset or diarrhea, but most of them are very easily taken care of. So nowadays, the treatment of kidney cancer is done with a series of chemicals, chemotherapy agents that are specifically designed for the kidney, and the long-term side effects are mild, and they certainly can be adjusted and taken care of. They're not the severe side effects, like I said, like in old-time chemotherapy agents that we used to use. So the side effects are there, like I said, constipation, diarrhea, things like that, but they're not severe at all.
So then maintaining one's lifestyle or work could be quite possible if they're undergoing treatment for this type of cancer.
Yeah, we encourage them to stay working. We encourage folks to stay working.
Yeah, keeps their mind off of things, I would say. So as far as then someone living with one kidney after the kidney cancer and the one kidney's removed, their life can go on quite normally. I know, Dr. Bacati, you were saying that, you know, just hope, you know, for infection or anything else because it is the one kidney. So, but pretty much they live a pretty normal life, don't they?
Yeah, I mean, they can work. You wouldn't notice them any different. They don't look sickly. They don't lose weight. They don't lose their hair. So they're living pretty much a normal life.
I think, Lori, as anything, it just prompts patients to take a little bit better look at themselves. Like, you know, they can't just eat the wrong foods all the time. They may have to watch their protein intake, which can put a stress on the kidney with too much protein. They may have to watch their NSAID usage, you know, not a lot of, you know, Advil, Leve, or Motrins, which can be nephrotoxic. You know, they'll watch their sugar, they'll watch their blood pressure, they might exercise a little bit more. You know, they might even wear a medical alert bracelet. You know, sometimes we forget about that, but if you only have one kidney and you can't talk and tell somebody you don't have it, then, you know, if you're unconscious in a car accident or something like that, you need to kind of wear a medical alert bracelet to let people know that you only have a solitary kidney. So there are some lifestyle changes, but the kidney is a remarkable organ. It does, when you have one kidney, it does hypertrophy. So the other kidney that's remaining can sometimes take up the load of the other one and, you know, actually, you know, do the job of two in terms of one.
Okay. So then and you did say this earlier, Dr. Preed, maybe we could reemphasize, the actual cancer survival rate based on stages is what? Could you reiterate that, please?
Yes, and that's an important thing, that kidney cancer, when confined, stage 1 or 2, you know, just confined to the kidney and not showing any involvement in the perinephric tissue or the lymph nodes or involvement of the blood vessels, its survival rate can approach almost 90%. when surgically removed. Obviously, it drops down a little bit if there's maybe a small lymph node involvement or some small involvement of the perinephric fat around the tumor, or if you have one of those more rare subset of more aggressive kidney cancers like sarcomatoid or medullary cancer, which can be devastating cancers, and thankfully they're rare, but those subset varieties can be much more aggressive regardless of what their stages are. When you get down to a stage 3 cancer, locally involved, it drops down about 55 to 60%. 5-year survival on a stage 4 metastatic kidney cancer, 5 to 10%.
Okay. So as far as support groups, doing things like this, letting the public hear and understand it a little bit better, are there support groups in our region that help people who are struggling or who are a little uncertain, a little fearful about moving on with their life? Do you know of any distinct programs for this type of cancer?
There are a few resources available. The American Cancer Society does run resource groups. They help out patients who are getting treated, give them rides and things like that to treatments and stuff like that, but they do have group sessions and all that. We commonly run survivor kind of group sessions at our office and have stuff for counseling. We have counselors there for those patients who are taking it hard. So we do have resources both privately and on the public side through the American Cancer Society.
Okay.
And locally also, NRCI has done some work in cancer field, and there also is a major resource for self-help groups.
Okay, good. And then as far as the cancer, their fear, as I just said, people would go to these groups hoping that maybe their fear of something else happening or it reoccurring. What are the chances of that type of reoccurrence?
I think the size of the tumor and the particular variety of the cancer probably offer the most ominous risk for recurrence. There can be metachronous kidney cancers that can occur in the same kidney if it was spared, or in the other contralateral kidney, and that's why once patients are operated on or they're taken care of, they are still followed like on a biannual basis, at least for 4 to 5 years, serial CAT scans, blood work imaging, history and physical exams to make sure that we don't see changes or recurrences in that. As time goes by, we obviously order less x-rays and become less intensive with doing the blood work and follow-up, but nobody's really off the hook. We kind of follow people, sort of forever for that. Large tumors, greater than 7 to 10 centimeters, I think, are more ominous. And, depending on what the final pathology showed, that if there was any invasion into the fat or the blood vessels at that time, make it more worrisome that there's a chance that it could come back. Smaller lesions, less aggressive lesions, obviously do much better. So
the question always is, for any form of cancer or anything, what can you do to prevent it? Is there something specific? I know that's a loaded question, but what are things to do, if they are, to try with this type of cancer to be prevented,
and
if anything?
If I could add to that, since we don't have a screening test, are there risk factors for the general population? Are there things, exposures and things like that would put someone at risk for kidney cancer?
Well, obviously, smoking has always been touted as one that would increase your risk for kidney cancer. In the past, unlike other cancers, breast cancer and colon cancer and bladder cancer, which have a direct relationship to cigarette smoking, kidney cancer, not so much, but it's definitely involved with it. Hypertension, obesity, age are obvious risk factors. Long-term dialysis, so patients that are on dialysis who have end-stage renal disease, the longer they're on dialysis, they have an increased risk of developing renal cell cancer just because of doing dialysis. We're not really sure what the mechanism is with that, but that can certainly happen. Chronic long-term usage of analgesics, especially the NSAIDs, have been touted. Exposures to polycyclic hydrocarbons, chemicals in production, can certainly be risk factors for kidney cancer. Interestingly enough, I found this statistic out that if you had a hysterectomy, you have a double the chance of getting kidney cancer. So having a uterus is somewhat protective, and a small amount of alcohol usage, when they always tell you drink too much, you get bad things, a small amount of alcohol usage actually is protective for kidney
Wow.
cancer, believe it or not.
So go get your wine after this, is that
There
what
you
you're
go.
saying? There you go.
The common reason is immune suppression of some kind, particularly organ transplants. When the immune system is suppressed by various medications or the organ transplant, they have a higher risk of getting cancer, including kidney cancer.
Okay, so because we're talking about this, Dr. Farrell, you were stating that, again, there's no distinct test. So have there, or are there anybody can answer this too, but to your point, are there is there new research or new ways that they're looking at? Because I know, Dr. Priet, you had told me a while ago that there seems to be a larger than usual influx of this type of disease locally. So are there any ways that we can, or that's out there, or they're trying to develop research to help in this realm or to possibly be treated in advance?
Well, since kidney cancer has always been a surgical disease and not been very responsive to conventional chemotherapies or radiation therapy, and back in the day, prior to all the imaging studies that we've had to find these incidental lomas, you know, surgery was really the mainstay. And prior to CAT scan, my father could probably attest that he diagnosed more patients with stage 4 kidney cancers back in the day than, you know, we certainly are doing here today. They've tried to look at different techniques of trying to improve survival rates with it. Immunotherapy has been a popular one, and Dr. Grin could probably touch on this, but not as responsive as surgical therapy, but 10 to 15% of the time using things like interleukins or interferons have shown 10 to 15% chance of response when patients have had widespread disease. And this has now moved on to what we call targeted therapy. And Dr. Grin, you're probably best to touch upon the new targeted therapies that have come out for kidney cancer.
Yeah, we've had, over the past 10, 15 years, we've probably had about 7 new drugs for kidney cancer, and they've taken those about as far as they can go. They extend life in patients with metastatic disease, they extend life, but they don't cure you. Now, there's a whole new series of immunotherapies. You see them on TV. Some of these ones that trick the body's own immune system into chewing up a tumor. They were initially developed for lung cancer, but we're finding them applicable to a whole number of tumors. In particular, recently they've turned on against bladder cancer, and they're doing the studies now against renal cell cancer. So these new immunotherapies that trick the body into attacking a tumor, whereas it didn't attack the tumor initially, these are where the new research is. This is where the future is right now.
Okay, so I would like to, as you, Donnie, you said before, your dad's in the audience, as is my mother. And are there any other kidney cancer survivors with us, beside the two, Dr. Priet Sr. and Cadnor N. down, we're throwing that in. So they're in the audience, they're here. So I think it's important to know, Dr. Priet, you're not mic'd, so I'm just going to answer for you. But I know that Lisa has the mic, if you don't mind. Your son operated on you, and you, many years before, operated on your dad. So I said earlier, it's history repeating itself. So what went through your mind as someone who has been doing this for so long as a urologist and helping cure someone? Now you're diagnosed with the same illness. How did that feel, and what were you able, how did you rectify that?
Well, I went to really to my son because I thought I had some kind of a GI dysentery problem that caused my urine to become very deep colored. And in the course of him seeing me that day, he checked the bladder and the urine. He said, "Dad, there's no blood in your urine. It's not, you know, it's not an infection or what have you." So he said, "Let's get a CAT scan." So a couple of days later, we got a CAT scan, and it wasn't until right after we had it done that John, he'll be able to tell you, he says, "Uh-oh," I'm looking up in the kidney, and there it is. It was obvious to me, you know, shock, stun, but as soon as he and I looked at it, I says, "Okay, I know what we got to do." and we eventually did get it taken care of. But it's it's a whack in the head to think that you've been dealing with this all your life, treating people with it. I can't, hundreds of nephrectomies and things like that I have done. And to see it happen to you is, it's just really mind-boggling. In addition, we also found a kidney stone that I never had symptoms from. So now you have a kidney tumor and a kidney stone and no blood in the urine. Never saw it, and you can't even find it under the microscope. So again, you have to have a real high sense of suspicion. Whenever you don't feel right for some reason, you may be looking in the wrong system, but get the testing because it's going to tell you what's going on. And in retrospect, I probably do, I had been getting checked by a family doctor because you have the usual panoply of medical problems, hypertension, cholesterol, diabetes, you name it. As you get older, you're going to attract these diseases like Velcro. And the upshot is that you have to have a high sense of suspicion going on when you're being seen by whatever doctor. I remember in the last two years now, my kidney surgery was a year and a half ago, but for a year or two prior to that, all I remember being abnormal on my blood tests, which was done every 6 months, was just a slight elevation of one of the liver enzymes, not even 10 points. And my family doctor and I, we kind of knew that I did have some adverse reaction to the statin drugs that I was taking for the cholesterol. And so we switched to one, and that brought it down to just a tad above normal. Only one of them, not all of the liver tests. Since the surgery, liver tests are perfectly normal. Now, is it possible that that there was some paraneoplastic thing that was going on that caused the slight elevation of the liver enzyme? Nothing turned up on the liver in terms of the CAT scan. So there are a lot of things that can occur that you might just dismiss out of hand as okay, it's related to this drug you're taking, so forth. A little bit of anemia. And in retrospect, when I look at myself at that time a year and a half ago, I lost about 5 pounds or so over a period of 6 months. Again, it was during the summertime, you're sweating, you're this. You can make 1,000 reasons why you lost a little bit of weight, why you're this. But when you have the surgery and the tumor is out, all of a sudden, things are back to perfectly normal. So you have to have a very high index of suspicion going on this. And I got to say that John Farrell, he spotted that thing right away. Pointed it out to me. And in addition, it did show that I had a little bit of diverticulitis. So it was like we were on the right track, but it was like you're diverted. Say, okay, off to the left here. So that's, it is a little bit eye-opening, even for somebody who thinks he's smart enough that he could, decide when he's getting a kidney tumor or not. Or even a kidney stone.
Were you nervous though when your son? Now I know he's your son, we were talking earlier, and I said, because you're always making sure they do it right, and that's just a parental thing. What was your feeling about that?
I had worked with him for 5, 6, 7 years. When he first came into the practice, and he's been doing this for 15, 16, 17 years now. I don't know exactly. But I had the utmost confidence in him because I knew how he could operate. I mean, his hands were much more deft than mine were. It is. And so it's like anything else. You pick the person that you're most comfortable with. And to me, it was, I knew that the other fellows, if he couldn't do it, I'm sure the other guys could do it. But I had the utmost confidence in him, and it turned out fine.
No.
So I think, in retrospect, I may have put a little more pressure on him
Than you-
he
the opposite,
that I
yeah.
was worried about.
Yeah. Well, I think it was fortunate for me, as we told a little bit earlier, that Donnie and I had met a couple years ago, because he's on the board of Broadway Theater League, of which I was, for a while, the executive director, and we became fast friends, and I had his number from my cell phone, and when my mom was diagnosed in December, we got out into the car and I called Don and he answered, and we were driving down the street, and then she wanted me to call Lisa Thomas, and my mother was, being an RN, she thinks, she said to me, how do you have his phone number? And I said, Mom, he's my friend, so that helped so well to be able to call him, and he took such good care of us. My mother loved him, and it just all worked out good. And my mom, for 1 minute, Mom, if you want to say a little bit of what you did, what happened for you, very quickly. I'm going to ask you a question, and then we can end it, because we're going a little over with these docs up here getting, let's go here.
That means that you know I can talk.
Yeah, but hold the mic down a little. Mom, Dr. Priate did your surgery, and
Yes.
you are about 6 weeks or so post-op. You're running around doing your stuff a little bit slower, but you're getting there. But what would you say to anybody who has done this, and the fear you had and where you are today?
That thank God that things showed up when they did through the urinalysis and the contrast scan, that it was diagnosed quickly, and we made fast steps in doing what we had to, contacting the pro.
And so, you just want to tell everyone you're feeling wonderful, correct? For all this?
Yes, I
There you
feel
go.
great.
Do you want to say thank you to Dr. Priate?
Yeah.
Publicly? Say it again.
Thank you, Dr. Priate.
There you go.
Thank you,
So,
Heather.
Behind me has a daughter who is going to have kidney surgery because of a tumor. So maybe she would like to say something.
we have 1 minute if you can, because we have to wrap it up.
I would just like to say thank you to Dr. Priate for the time and the patience you had with us when you saw us to give us that diagnosis.
Aw,
Thank you. She's
See
going to
that?
do great.
there you go. Thank you so much for participating. Good luck to your daughter and Mom and Dr. Priate. It's all good. So I'd like to thank this wonderful panel. Is there anything you guys need to say that I maybe did not cover?
I think I would like to say that the care and approach that we have to kidney cancer or any cancer, now here in Northeast PA, if it wasn't for what I've learned from my father, who started my surgical practice, and my esteemed colleagues right here who allow me to have what I feel we've put together between surgery, radiation oncology, and hematology oncology, one of the finest programs of surgical, medical, and radiation care for cancer today in the Northeast. The old axioms of you have to go out of town and you need to have special opinions from different places. We've shown that we can do it here. Between our techniques, the access to the cares that we have, and probably what I think is even more important is the nature of these physicians. Between the guy here who helps me diagnose them and the patient and the doctors here that help me treat them, we're your friends, we're your family, we're your neighbors. But we have the skill and the care to be able to do this. I think we have the reassurance to let you know that we're good at it, and that we also have good caring and ethics, that we take care of you, we walk you through this, and we try to make something that can be very ominous, very livable. And for our medical students that are here with us, I want to say this is where you're going to be sitting someday, and these are the people that you're going to be treating, your friends, your family, your neighbors, and this is how it all starts. So I applaud them for wanting to learn and being the next future, and I'm sure they'll be sitting at a panel like this someday, with more advancement and doing things even above and beyond that we can do here today. But I'm very proud of my colleagues, and I'm very proud of this institution, of medicine and surgery that we've done here in Scranton. I'm very confident that we have shown, our patients, our family, friends, and relatives that we are the future, and we will do good.
I will say amen, and thank you very much for, we're
Yes.
all in agreement.
There you go. Well, good luck to you students, too. Thanks for coming today. So, everyone, this has been our Program 10 of the Lackawanna County Medical Society's Public Health Education. Next month, we're going to have Women's Health issue talk with Dr. Tina George. She'll be here, so look out for that. And I'd like to thank our panel again and tell you exactly who they are. So, down here to my far left, we have Dr. Bacati, who is a radiation oncologist. Next, we have Dr. Grun, who is a medical oncologist. We have Dr. Don Priate Jr., who is a urologist, and then we have Dr. John Farrell, who is a radiologist. So thank you guys for your time. We appreciate it, and we'll see you soon, okay?
Thank
you
you.
very
Thank
much.
you, Lori, very much. Appreciate it.
Thank you, everybody. We'll see you next month. I'm Laurie Cadden.